Hello, I'm going to begin this lesson about COPD with a little reenactment from an ER scene. Hi, welcome to the ER. Can I have your name and date of birth? My name is Dorothy MacArthur, 8/17/1956. Tell me what brings you to the hospital today. I just ain't feeling well. Explain that for me. I just don't feel like I can catch my breath. You can't catch your breath? Yeah. Okay, well, what other respiratory symptoms are you having? I cough a lot. Is it a wet cough or a dry cough? Both. Are you able to cough up any mucus? Well, sometimes, yeah. Is the cough related to seasons of the year, perhaps? I just can't tell. I've only had it for a few months. Do you have fever? Yes. Do you smoke? I did. I quit. Smoke cigarettes, cigars, vaping, or marijuana? Cigarettes. How many years did you smoke? About 10? Yeah, about 10, I believe. On average, how many packs per day? I would say 2. So when did you quit? When I started feeling bad, that's when I quit. So a few months ago. Yes. Well, what makes your symptoms better? When I lean forward, maybe over my counter or something? I just don't really have much. That makes it better. That's why I'm here. Well, what makes it worse? Oh man, I think going outside, especially in the afternoon or midday, it's just so hot. It also gets worse if I get active. Any activity will make it worse. Can you go upstairs? No, definitely no. Could you have gone upstairs a year ago? Slowly, but definitely yes. What did your normal activities of the day look like before all of this? I used to get up, I used to make my own bed, do the laundry, let the dogs out, maybe run some things around town for my husband, get groceries, and now I just get so winded just getting out of bed and brushing my teeth. Go on. Well, all that doesn't sound like I do much, but I do feel like I'm getting worse. If we were to compare your symptoms maybe to how you were a year ago, has a lot changed for your breathing? Oh, for sure. Okay. Any swelling in your feet or ankles or waist area? No, not that I know of. Have you had any nausea or loss of appetite? No. Any unintended weight loss? Maybe. You say maybe? Well, I don't weigh myself. Okay. Are your pants fitting a little looser? I'd say so. Okay, well, what are your bowel habits like? About once per day. Soft, formed? Yes and yes. Any concerns or changes? None. How about your strength and coordination? Good. I just fatigue in no time. Have you taken any medications lately, prescribed or over the counter? Some vitamin C, because I don't know if I have a cold. Maybe some that guaifenesin, Robitussin syrup stuff. Okay, are you on any other medications? Nope. What do you think is going on? I think I got that walking pneumonia. Susie had it at church, so I think I does too. Okay, well, I've completed your triage report. I'll have you take a seat and I'll let the doctor know that you're here. And blink! Look at the time. You are back in the present. That was you 1 year from now in the future doing a health history intake on a patient. Now, we are on the outside of your story talking about you. It looks like something from Ebenezer Scrooge's when he had to give the commentary about himself in the future to the Christmas yet to come ghost. which would be me. This conversation will most likely take place between you and Mrs. MacArthur. Aren't patients' answers so unique, so non-textbook-like and vague? Lord knows, too, that some patients ramble and some give one-word answers. It's very challenging. But your knowledge about diseases and medications will make you a much better interviewer. You can ask targeted questions. At the end of the COPD lesson, we are going to be taking care of Mrs. MacArthur again. And yes, if you had to listen to my interview there, I intentionally left out I intentionally left out a few good interview questions. In fact, what I would like you to do is watch this 5-minute video and think of maybe 2 more questions that should have been included in your interview to Mrs. MacArthur. Barrel chest, sitting up, check. Hypertrophy, trapezius, shoulder muscles, check. Shoulders swung forward, check. Visible ribs, check. Thin arms, and check. Yep. We can see COPD sometimes a mile away, especially when I see hypertrophied traps. Yeah. Okay, not these kind of hypertrophied trapezius muscles. Although, these are nice ones. I should quit staring. I can't. I don't know if I'm staring because I like or because it's borderline gross. The jury is still out on this one. Okay, COPD, right. Although COPD technically involves 2 separate diseases because of the pathological processes that are at work, however, most patients will have both conditions at the same time. So it is possible for some patients to only have emphysema and not bronchitis, and vice versa. For the most part, though, I'm going to talk about COPD as a whole, and most patients have COPD as a whole, but there are some distinct differences that a nurse should know, like when patients with chronic bronchitis, will they need mucolytic medications like guaifenesin to break up the excessive mucus that their body makes? Yes. Then patients with emphysema may benefit from lung reduction surgeries, aka lobectomies. Small differences, because you do that for one, but maybe not the other. It honestly really just kind of depends on the patient and their symptoms, but we're going to study this together and I'll point out the differences. The definition of emphysema is loss of lung elasticity, loss of alveoli surface area, and chronic hyperinflation of the lungs. Let's talk about some patho there. Less elastic alveoli mean that they are flabby and they are inert. I mean, what moves more air? A balloon that is blown up to capacity and then let go? Or a balloon that's blown up, just inflated from its flat shape? And which balloon has more surface area? The big one or the barely blown up one? Right. Alveoli are meant to expand greatly with air, and it just sort of passively releases because of its awesome elasticity. But in the case that we have extensive damage, its elasticity is gone. Air trapping leads to active exhalation rather than passive exhalation. You have to get it out, to get the air out. And through this, the diaphragm is actually going to flatten out to compensate. And then the intercostal muscles pick up their part-time work to full-time work breathing employees. They are no longer stay-at-home moms or dads, can't be prejudiced, and they gotta work to make ends meet. And more muscles, more working muscles means increased demands on the O2 and more chances of fatiguing muscles from overuse. Looks like the neck muscles, chest wall, and abdomen too is going to get in on all that breathing action. The vicious cycle can lead to a continuous cycle of inhaling before exhaling. Normally it's But in our case of our emphysema patients, they may be like, we call this air hunger. Right, air hunger. We just can't get enough air in, and they kind of grab at the inhale. Most cases of emphysema are associated with smoking or chronic exposure to other inhaled particles, such as wood smoke. Who puts out fires? Firefighters. Right, they are prone to COPD. Or anybody exposed to biomass fuels, such as pollution, chemical fumes, such as maybe somebody who's painting or even sanding, and dust. Excuse me. I like to look at demographic maps of conditions because these maps have some serious data that can be very useful. It can be misinterpreted also. Like, let's look at New Mexico and the Arizona area. They have some serious COPD cases, don't they? Maybe it's because that's where a lot of immigrants live. Immigrants may not have access to health care or to health prevention education. Maybe cigarette smoking is a norm within their community. Look at the Appalachian Mountains in West Virginia and Kentucky. Could they all be chain smokers? Or maybe they are inbreeding with families lacking genetic diversity? Or actually, is that where the coal mines and factories are with a lot of exhaust? Anyway, if you want grant money to address a health disparity such as COPD or any disease for that matter, grab a demographic map from CDC and you can make any assumptions that prove or disprove your case. I love looking at those. Chronic bronchitis is not an alveolar problem. It's an airway problem. Chronic inflammation from a trigger or irritant increases the size and the number of mucus glands in the airways. The bronchial walls thicken, narrowing the lumen, and excessive mucus is now produced. What loves a warm, nutrient-rich bed of slime? Opportunistic organisms. Who is going to have a chronic lung infection or lots of episodes of pneumonia? This patient. The chronic bronchitis patient. Let's revisit that future memory, I guess, that we are going to have with Mrs. MacArthur. What irritants do you think Mrs. MacArthur exposed herself to in the interview? Wish we could put our finger on it. Anyways, smoking is the greatest risk factor for bronchitis. Smoke fumes impair cilia from clearing the bronchi of mucus, cellular debris, and fluid. This process over and over again several times a day can lead to damage over time. Let's face it, nothing good can come from repeated, consistent exposure to something over a number of years. One piece of data we need to know from our patient is how many packs did you smoke over how many years? Who cares? Well, the patient care and nursing interventions are going to look quite different for someone who smokes 2 packs per day for 10 years as compared to someone who smokes a half a pack per day for 10 years. In fact, with a little bit of math and estimation, you might be able to figure out if a patient has stage 1 COPD. I believe the stages of COPD go from 1 to most severe, which is 4. So, someone who smokes 1 pack per day for 20 years probably has stage 1 COPD, meaning they have to have a 20-year pack history to develop COPD from smoking. And what this means is stage 1 COPD, the patient is 80% or less of their normal lung volume, and there is slight airflow limitation. Because onset is so gradual, people don't even know that they have COPD usually at this point. They just think, well, I can't probably get around, I'm older. Not like I'm young anymore. It's usually when they are in stage 2 COPD and their lungs are 80 to 50% capacity that they now have symptoms of coughing, wheezing, and shortness of breath that they will now reach out for help. So, how do you calculate someone's PAC history? Here we go. Stare at this for a second, or two, or if you're like me who is not good at math, I may have to stare at it for a few minutes. All right, you got it? Now, for my non-smoker students and friends, there are 20 cigarettes in a pack. Mrs. MacArthur tells me she smokes 10 cigarettes for 40 years. And I'm going to ask you, what is her pack history? She smokes 10 cigarettes. There's 20 cigarettes in a pack. Did you come up with a pack history of 20 years? Correct. This means she most likely has gotten stage 1 COPD, but probably at stage 2 because she's symptomatic. Anyway, most patients with a 20-year pack history, once again, are in stage 1 COPD. They don't even know it. FYI, I hate those social smokers who tell me I smoke 3 to 8 cigarettes when I drink. Okay, well, how often do you drink? 3 to 4 times a week. Then I start asking, well, when did you start drinking? Since college. Okay, so in my brain, I'm giving the patient a stink eye. Not because they smoke, but because my math is not my strong suit, and now I've got to figure it all out. What is their pack history? Back to what I was saying. Causes of chronic bronchitis. They are pretty much the same. Environmental and other factors like those of emphysema. And I will say patients with chronic bronchitis can also have asthma, which leads to their chronic bronchitis. Let me reverse that. Patients who have uncontrolled asthma can end up later in life having chronic bronchitis. Okay. Now, there is a genetic type of COPD. Patients will have all those COPD symptoms, but no history of exposure to pollutants and whatnot. It's called alpha-1 antitrypsin deficiency. And it looks the exact same on the outside as regular old COPD. It occurs, though, in those who are in the 30-ish age, and it's given by 2 recessive gene faulty alleles. Like the parents both had recessive genes for this. Now, there's going to be no change in how you treat this patient, but it would be very important to do some genetic counseling. And warn them that smoking is extremely contraindicated. Caucasians in the numbers game do have more incidences of COPD than Asians and African Americans. Who gets COPD more, males or females? The answer is males. Males get COPD more than females. They are usually, patients who get COPD are usually of advanced age. Do ask about chemical and fume exposure, and I mean from the janitor to the plane mechanic. What is their exposure and irritant risk factor? Figure that out. Does emphysema run in the family for reasons that we just learned on the previous slide? What habits do they have, such as smoking or vaping? Does smoking marijuana count? Please tell me you said yes. Okay, good. Want to know some juicy questions that are rich in details? Yep, get your pens out, write this down. All right, number 1 set of questions. Their activity intolerance. Do they have activity intolerance when they bathe, when they dress, during sexual activity? How about eating and sleeping? Sleeping? Yes. I mean, do they have orthopnea? Thus, they sleep in a recliner. So ask how they sleep. And orthopnea, for those who need a refresher, it means difficulty breathing while lying down. Number 2 questions. Detail those breathing problems, such as, do you have difficulty in speaking, or do you have breathlessness and difficulty speaking? How about the duration of you when you're speaking? Is it shorter than usual? Do you have worsening wheezing? How about coughing? Shortness of breath while resting? Or do you have a shortness of breath with activity only? Which, FYI, we call this exertional dyspnea, when you have shortness of breath with activity. Ms. Tonis, can you use that word in a sentence? Yes. Mrs. MacArthur is not able to complete her ADLs due to exertional dyspnea. Done. Do ask if humidity is a trigger. My neighbor has COPD, and I will actually never see him out of his house in the summer in the afternoons because he feels like he cannot breathe and that he's being smothered with moist air. So do ask them if there's any correlation with their symptoms and the humid environment. Do ask them to describe the cough. Is it wet sounding? You are not going to get an example. I'm just saying. I can't produce that sound for you. It's very distinct. Is it wet sounding or is it dry? And it's really important to know how long had they had this cough. Coughs greater than 8 weeks are very suspicious for something like COPD or something even worse, such as cancer, or maybe even asthma that is uncontrolled. So always ask about the duration of their cough. Now, let's find out the deets on a patient's sputum. What's the color? Is it brown, rusty, yellow, or green? Let's find out about the consistency. Is it thin? Is it thick? Or frothy? I know, I just ruined your lattes. But is it frothy? How about the amount? Is it small, moderate, large, or copious? Oh, copious. That means like it's gooey in their mouth, like they're chewing gum. Yep. Let's see. What did I say? Copious. Oh, what time of day does their sputum production, is the sputum production highest? It is usually highest in the AM because a lot of mucus builds up overnight, and the patient usually reports a pretty wicked cough upon awakening. Wakey, wakey, cough, cough, hack. Do ask the patient if they have had unplanned weight loss. This occurs as COPD increases in severity. The metabolic demand is increased because of the work of breathing, plus they can't eat or prepare food due to the dyspnea. That stinks. Kind of wish I had that problem. No, I don't. I don't know. I suggest asking your patient to do a 24-hour food recall. Now, 24-hour food recalls are totally subjective and get a pretty bad rap because some people feel that they are a poor reflection of average intake, but they do have some use in seeing how much or how little a patient may eat. Note, all right, weight changes. If the patient reports weight gain, you should really start thinking about heart failure and that it may have already set in and occurred. Specifically, the right ventricular heart will fail because of extensive pulmonary disease. What is that special name for the right side of heart failure? Cor pulmonale. That is actually Latin for heart lung, like literally. Okay, that's it for your health history. Sorry. Okay, general appearance. Boop. All right, what we see here is your patient is going to be leaning forward. Their posture might even take a leaning forward, curved, I'm going to even say kyphosis type shape. Their mobility is going to be slow. No, they are not going to have range of motion problems. They are just going to be slow. You're going to notice that they have lean body builds, and this is because, well, watch your first patient that you have that has COPD be morbidly obese. Now, look, we are talking about generalizations, not rules, but generally they're going to be skinnier. Overall, hygiene is going to be poor. I personally get pretty upset when my fellow nurses complain and gripe about a COPD patient. They're so nasty because of the poor hygiene, blah, blah, blah. I mean, if I can't breathe, the last thing I want to do is change my clothes or scrub my body. Definitely not brush my hair. I need those shoulder muscles for breathing rather than non-essential activities. So don't judge a patient whenever you see that they have poor hygiene. That's what I'm trying to say. We are going to see the neck muscles enlarge. Their shoulders are naturally going to be rolled forward, and the patient will often naturally assume a tripod position. That's where their arms are up resting on something, or maybe even their knees. They do this usually on their own, kind of like a trial and error, and they will report that it is easier that they breathe this way. All right, so jot this down in your memory so you can ask your patient, do you find yourself are leaning forward with your arms propped up? That's what you're going to ask. Okay, assessment. Your rate of breathing might even be 40 to 50 respirations per minute. If you count 40 to 50, you need immediate medical intervention, especially if respiratory movement is asynchronous and it is jerky, it appears uncoordinated. And what I mean by that is like the belly will like stick out as they're trying to breathe. Usually when you suck in, your belly goes in. But if it's asynchronous, your patient is working very hard to breathe. Notice if they have asymmetric chest expansion. Maybe there is little to no chest excursion whenever you do that on the back. I apologize, I clicked too quickly. All right, back to what I was saying. If you notice that the person has little to no chest excursion, you can probably guess that they have some COPD or breathing issues. We are going to see increased vocal fremitus, usually in pneumonia or maybe lung abscesses. However, on our COPD patient, we're going to have decreased vocal fremitus. So put your hands along their backside and make them say 99, and it should get quieter all the way down. This may let me know that they may possibly have emphysema. If we were to percuss all along their lung fields, we are going to notice that they are hyperresonant. If we were to listen to them with a stethoscope, we're going to note wheezes possibly on inspiration and expiration. I would not anticipate us to hear crackles, maybe some reduced breath sounds, but crackles usually mean like collapsed alveoli, like in pneumonia. But do know that you will hear decreased breath sounds and wheezes. Now, in my patient who has bronchitis, if they are having an exacerbation, I'm probably going to hear coarse breath sounds or rhonchi in the upper airways. Have your patient cough and re-listen. We do want to know if the patient can clear their own airway. If they cannot, I know I need to monitor them more and make sure their secretions are thinner so they can get it up. Now, what if you were to hear a silent chest? Silent chest. You need to be thinking obstruction or a pneumothorax. A silent chest meaning you hear nothing. All right, we already talked about the barrel chest. Okay, I actually see that I might have not talked about this. Our patients with chronic bronchitis may have just a blue tinge to their lips. They may have a dusky appearance to their skin. It's not like bright, healthy pink, you know. They may even be a tad on the pale side, and there's going to be excessive sputum production. Now, I know it's been a hot minute since you have done your last cardiopulmonary assessment on a person, but I've provided a link to an excellent video I found on YouTube. It's about 9 minutes, but it is the best 9 minutes of your nursing life. Last comment I want to make is about cardiac changes that may show up on your COPD patient because the lungs and the heart are super connected. All right, you are going to check the ankles and the sacrum for pitting edema. Will edema, if related to the heart, always show up as bilateral, or can it be unilateral edema? Well, since you asked, it will be bilateral. You will never have unilateral edema in heart failure. Your patient has something else going on if they only have one leg swollen. You know how we ask our patients to give us their pain on a scale of 1 to 10, and then we will continue to use the same exact scale? Well, we are going to do the same exact thing for our patients with dyspnea. You can use the scale of 1 to 10, 0 being no dyspnea, 10 being the, can't breathe at all. This is another little assessment tool like that. It's called a visual analog scale, and you ask them to mark their perceived difficulty breathing with an X along the spectrum here. And if you want to get fancy, you can actually measure the placement of their X, and you can record it in your electronic electronic record. Yeah, I meant to say health record, but yeah. Oh, your person is going to experience lots of isolation. They're going to report whether it's the fatigue, the medication side effects, just the coughing and the sputum production, they are going to self-isolate, and that is never good for a person. Oftentimes they are living in crowded situations, and the transference of respiratory illness can happen pretty quickly. Do inquire about their economic status to make sure that they can pay for their medications and obtain them. Do assess a patient's anxiety and fear, maybe about work, maybe about family roles or social roles, or even their sexual roles. Explore those areas and discuss it with your charge nurse, with the doctor, and with the social worker. Try as best you can to get them to express their feelings. I like to do the obvious and say obvious statements such as, I hear COPD really changes your lifestyle. Would you agree? Tell me more about that. Yeah. And you can also state like, oh, you seem upset, or you seem to accept the disease very well. I mean, can you tell me about that? Give them that opportunity to talk. Support groups are fabulous. Support groups are great in general. I feel like we should all just go to one. Okay, now we're going to talk about some laboratory assessment data that is going to be possibly done on our patient who has COPD. This kind of goes across the board. Anybody with breathing problems is going to be subject to an ABG, or blood gas. What's interesting about COPD patients and their blood gas values is that they are going to be CO2 retainers. Their CO2 level, their CO2 level is going to be constantly up. And we are going to say, well, my goodness, their CO2 is up. Let's look at their pH, because their pH value is extremely important. And if it's out of whack, then we have a different issue. But if it's, say, normal, then our patient is going to have compensated respiratory acidosis. Most COPD patients have compensated respiratory acidosis on their blood gas values, and we don't do anything. We just live life. That's how they typically are, and there's nothing you can do about it. Do check a person's pulse oximetry on the vital signs. Let's see. Now, I really need to kind of go back. Not all COPD patients are CO2 retainers, but do know that a lot of them are in advanced emphysema. Let's grab a sputum sample, especially if we are suspecting an upper respiratory infection. Get it up, sir. Cough it in here. Cap it off. Can they cough up a sample in a denture cup? No. Get it in a sterile specimen container and get that sample down to the lab within the hour. Don't need to sit up on the table overnight. Grab it and go. CBC, we're going to do a CBC on them, and we're going to confirm the presence or absence of an infection. So I'm actually going to look at their white blood cells to see if they're elevated, if they're greater than 12. Let's look and see if their hemoglobin and hematocrit is it going to be low? Is it going to be high? Answer is it's going to be high. Believe it or not, COPD patients oftentimes will have polycythemia. And this is because of the body's own efforts to compensate for hypoxia is actually going to make more red blood cells. So we're going to have a higher H&H. Do double check somebody's serum electrolyte levels. If a person is acidotic, meaning their pH is kind of on the lower end, less than 7.35, then our electrolytes are going to be altered, specifically our potassium. It's going to be elevated, like greater than 5. If a person is younger and they have no risk factors such as smoking, but they keep having all these COPD symptoms, we're going to grab a serum AAT test, or alpha-1 antitrypsin test. And we're going to ask, obviously, about more family history of COPD. We are going to grab a chest x-ray on our person. We're going to rule out other lung diseases, and we're going to check the progress if they've had a previous x-ray done. And when I look at a chest x-ray, the wet read, so we call it, or maybe even the impression, it's going to describe it as hyperinflation, areas of hyperinflation, and they will even say the diaphragm is flattened. Now, best test here is a pulmonary function test. Pulmonary function test. This is actually going to diagnose somebody with COPD. They're going to, well, we talked about this, didn't we? Yes, we did, when we did asthma. Okay, but we're going to do a pulmonary function test for COPD patients too. And then our peak flow meters, those are just useful for a person to daily monitor how they are doing, just like our asthma patients. Let's talk about some management. This is the good stuff. I know I've went on a little bit, probably a little too much. Okay, focus. All right, nursing priority. Get the patient to be a partner in their care. Oftentimes they get this diagnosed, they feel like they're labeled, and now they're good. And that's all that they are, it's just labeled. But no, this is a lifestyle change that a person has to make. So you're going to help them be your partner. And the most important thing you can do is try to improve their gas exchange. And we're going to do this through medication therapy. Now, I'll get to meds. Now, the client needs lots of monitoring. What are we going to monitor? Well, we are going to monitor for level of consciousness changes, because if they are going to get hypoxic, their level of consciousness goes down. We're going to monitor them maybe every 2 hours for this. And if we do see that they're starting to get a little restless, we're just going to apply some O2. We're going to assess and try to prevent any further hypoxia. The breathing techniques that are extremely helpful are diaphragmatic and abdominal breathing. Diaphragmatic or abdominal breathing. This is going to reduce the stale air in their lungs and help in the times of dyspnea. Oftentimes, you can have a person lay on their back. Of course, they have to be well. They're going to lie on their back, and they're going to put a book on their stomach, like a heavy book, and practice breathing with their stomach, lifting the book and letting the book fall. Another breathing technique is pursed lip breathing. This increases resistance and prolongs air in the lungs. Pursed lip breathing. I tell them to smell the rose, and blow out the candle. Smell the rose, blow out the candle. All right, positioning. Our patients need to be out of bed at least 1 hour a day, hopefully a little bit more than that, but get them up 2 to 3 times a day. This is going to alleviate their dyspnea. It's going to mobilize secretions, and sitting up maximizes chest expansion, so reposition them and get them moving. Let's talk about coughing. Not coffee. There's actually a good and effective way to cough. So when are you going to cough? You're going to cough upon rising in the morning, before meal times. I know, right? Before meal times, so they can get and have less dyspnea while eating, and before bedtime. This allows them to have less interruptions. They are going to take small breaths and do mini coughs. And I'm going to do an example. They're going to go like that. So a little breath in and a mini cough 2 times following that. And as they cough, they're going to lean forward and actually even press on their stomach. I'm pressing on my stomach. I know you can't see. All right, I think I already talked about oxygen. No, I didn't actually. We need to put them on 2 to 4 liters usually of oxygen. That is usually enough to help a hypoxic COPD patient out. There is new SAT levels that are considered acceptable for our COPD patient, meaning I am not going to freak out if they are 88% on room air. I am not going to freak out if they are 90% on room air. What we are trying to do is have our person to, how do I describe this best? Have our person be on the lowest amount of oxygen, the lowest amount of symptoms, and usually if they are 87% and below, then I'm going to begin treating our person. But do look at their SAT values, do compare it to their symptoms, and we will actually permit them to be in the 88 to 92% range. Sometimes that is actually our goal for a patient. I should probably re-explain that. Yes, okay. If you walk in and your COPD patient who is on 2 liters of oxygen, you check their SAT and it's 89%, I want you to do nothing and smile and talk to your patient because they're probably just fine. Now, if your patient who has COPD is on 2 liters, they're 89%, and they're breathless when they talk to you, their shoulders are heaving a little bit more, and they can't tolerate any other position than sitting up, well, we may need to turn them to 4 liters of nasal cannula. Whatever we need to do to relieve the dyspnea, but try to stay in the 2 to 4 liters range. Now, can you actually go higher than 2 to 4 liters? Yes, but we really would like it to stay in the 2 to 4 liters range. And that's a long story. Why? Usually it's the CO2 retainer story, but okay. Our person is probably going to go home on home O2. That is if they fail what we call a walk test. A walk test means they are going to have their SATs tested on room air, sitting. We're going to take them for a walk. We're going to check their SATs midway, and then we're going to check their SATs upon sitting down. And if it stays consistently below 88, then we are actually going to qualify that person for home O2. But the person has to have a walk test first. I'm saying walk, W-A-L-K. All right, so they're going to go home possibly on continuous or PRN home O2. Teach the family that impaired cognition might be a sign of hypoxemia and to call 911 if that happens. Do not let them cook near a gas top with their oxygen. Right, no open flames. Kaboom! Some other exercise or some other management things that we can do for our patient is exercise conditioning. See her? Isn't she cute? I love old people. Exercise conditioning can improve function and endurance, but it can prevent deconditioning associated with patients limiting their activities. Really encourage them to walk until manifestations limit them, and then tell them to keep walking until 20 minutes of walking has been achieved per day. 2 address periods. We may need to incorporate a walker. We may need to incorporate oxygen therapy again, and they're going to do this, quote unquote, exercising 2 to 3 times per week. Okay, Let me show you this right here. Okay, this is what we call a cornet. It is a vibratory pressure device. This right here, oh goodness, is a flutter valve. This emits vibrations to the chest when blown into, and it's supposed to loosen secretions, and it makes it easier for them to cough up. I had this one patient and I was like, hey, you need to do this a couple of times, you know, an hour, 2 to 3 times an hour. Oh, I don't want to do it. I said, yeah, why not? It makes me cough. I'm like, okay, that's actually the point, so let's go ahead and do it. Oh, man. All right, some more COPD management would be suctioning our patients. In fact, here is an example of tracheal suctioning. What we want to do is do this PRN, not like every 2 hours, just as a patient needs it, especially if they are weak, like they have a weak cough and they can't expectorate, and you can hear it. You can hear the mucus. It's in there. Just get it out already is what you want to say, and you pat them on the back and they still like, okay, so you're going to lube it up, stick it down there, suction it all out. Not for long periods of time, just really briefly. Please reassess the breath sounds and look for any further dyspnea or tachycardia. Hydrate. Da, 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 da. Hydration, it thins the secretions, and unless it's contraindicated, get them drinking 2 to 3 liters per day. Use humidifiers on their oxygen as well. Do assess for any weight loss. Do they have any food intolerances, nausea, early satiety, which means they feel full quickly? Maybe do they have a poor appetite or even meal-related dyspnea? Ask those questions. Your malnourished patients can lose calories and protein to fuel their breathing efforts, and we need to make sure to restore their muscle mass, their strength, and possibly their lung elasticity and alveolar surface area, if we can. We need to identify our high-risk patients. We need to weigh them. We need to put them on a calorie count. Usually we do a 3-day calorie count. And we're going to give those numbers and consult with a dietitian. Their biggest meal of the day should be when they are most hungry and well rested. This is usually breakfast time. We recommend that they cough and use a bronchodilator before eating. And this little picture here of somebody drawing blood, this is a recommendation to monitor their serum prealbumin levels. That is a really good indicator of somebody's nutritional status, and if it's super low, we may do some interventions, such as putting them on Ensure or Pulmicort. Pulmicort is a very good supplement, and it has those basic amino acids for somebody with pulmonary diseases. Make sure to chew foods that are easy to chew. Did I say choose foods that are easy to chew? I did. Pick foods that are easy to chew and not gas forming, not like cabbage or something, because they will not be able to use their diaphragm if they have a distended stomach. Avoid foods that stimulate coughing, like crackers, little dry particles. Avoid caffeine products because that induces diuresis and they're going to be up running back and forth to the bathroom. Avoid fluids before meals. We want to make sure that they get the good stuff in and then they can drink whatever they want. All right, we need an anxiety plan because anxiety causes dyspnea and dyspnea causes anxiety. That's a very bad cycle. Help the patient understand this and a written plan of what to do. This can provide a lot of confidence and control. Look, patient, you got to do the pursed lip breathing here and the diaphragmatic breathing here, or call your friend at this number or this support group at this number. That really, really is helpful. And you've guessed it, they will probably be on Xanax or Ativan or lorazepam, any kind of drug that is effective for anxiety. So they'll be on anti-anxiety meds. Okay, let's make sure to improve their activity tolerance. This is going to prevent and lessen those acute exacerbations. A person may need some help with their ADLs. Tell them to pace themselves through it. Let them know not to put appointments in the early morning so they don't feel rushed. Maybe they can even use their oxygen during high demand times. You can encourage their family members to help. A lot of family members have the idea of, nah, she can do it, she'll be fine, but there's times where you're not actually enabling, you are being helpful. Teach a patient not to work with arms in the raised position. Not to work with their arms in the raised position. The arms are used for, or when arms are used for activities and not for breathing, it causes a whole lot of dyspnea. I'll even tell patients to move everything from the upper cabinets to the bottom cabinets. They should divide their activities into smaller parts. Little things here and there. And if it helps, start using disposable plates. I mean, any way that you can adapt is good. Encourage them to not talk when engaged in activity and to not hold their breath. Last but not least would be preventing respiratory infection. They need to avoid sick people, avoid crowds at all costs. And if they do live in a crowded area, ventilate the room, open the windows, and try to wear a mask if you have to. They do need their pneumonia and flu vaccination. They do need their pneumonia and flu vaccination. Flu is yearly. Pneumonia, it's usually 2 shots. 2 shots, about 5 years apart. Medications for COPD are pretty much the exact same for asthma, but focus is going to be on long-term medications and long-acting drugs. Stepped therapy is recommended in conjunction with patients' report of symptoms. And I don't need you to remember anything on the slide, just appreciate that there is a protocol that providers will follow in order to try to control a patient's COPD better. We are going to use beta-adrenergic agents such as albuterol and salmeterol. Which one is the long-term acting? The LABA, long-acting beta-adrenergic? Albuterol or salmeterol? Albuterol, right. They're going to use cholinergic antagonist or anticholinergic, such as ipratropium bromide. We are going to put them on methylxanthines. Can you remember that drug? Theophylline. And we will put them on corticosteroids. They are more likely going to be taking corticosteroids, the systemic ones, such as like prednisone, then we are going to see it being used in our asthmatic patients. We are going to put them on mucolytics. Excuse me. Mucolytics will thin and make any mucus easier to expel. The typical dosage for a mucolytic is about 600 to 1200 milligrams, maybe twice a day, like Mucinex. Patients need to increase their intake of fluid though, because it ain't going to do nothing if you're taking this pill. You don't have any fluid to loosen up the secretions. So you want the pill to work, you got to increase your intake to 15 to 2,000 mLs per day. I mean 1,500. Check this out. Another mucolytic. We call this one acetylcysteine. Read what you can there and see what it's used for on the label. For our COPD patients, do you want them to inhale it or swallow it? Inhale, right. It does a great job of thinning secretions, but it smells really, really bad. It's just supposed to smell bad, don't worry. It's got a sulfur compound in it. It's not like something you need to toss out. It actually smells like rotten eggs or a skunk. Do know that Mucomyst, which is the brand name for acetylcysteine, is not the same as Mucinex or guaifenesin. please do not get that mixed up. Those of you who are going to be my pediatric patient, are going to be my pediatric nurses, you will be giving acetylcysteine a lot to your cystic fibrosis kids. And do know that it's actually a very sticky medication, so you're probably going to want to wipe off their little mouths because there's going to be residue all over their mouth and face. This is a picture of Pepe Le Pew, just to illustrate that this is a stinky medication. Now, if our patient is, say, stage 4 COPD or end-stage COPD, and they are definitely having a lot of complications as a result of their diseased lungs, we have a few things we can do surgically for them. We could do a lung transplant. However, organs are pretty rare, and we're going to learn about transplantation a little bit later in the semester, but we could do an organ transplant. We must make sure, though, that they are end-stage emphysema and they have minimal bronchitis. They must have stable heart function and basically no cor pulmonale, and they must be able to walk 30 minutes without stopping. They could very well get a lung. We also have the option to do lung reduction surgery. It is more rare in those with COPD, but it is a possibility. What we do is we're going to remove the hyperinflated lung, and this is actually going to increase their volume of their lungs, and it's going to help enable them to have more residual volume. Less residual volume. Their tolerance increases too, and they are going to have to do a bunch of PFTs to determine which area of the lung is going to be in need of surgical resection. I actually have a couple of pictures here on the slide of a VATS procedure, or video assisted thoracoscopy. As you can see, there is a traditional lobectomy that we can do, or thoracotomy on a patient, but can you imagine the healing time and the infection risks as compared to a VATS procedure there? Yes, way better. This one gets a smiley face. So if a patient needs to, they should probably have a VATS procedure done over an open thoracotomy. But in either operation, the lungs are visualized either through video or direct, and they are going to deflate one lung and then remove the bad tissue. They're going to deflate the lung and remove the bad tissue, expanding the space in the cavity for breathing. Post-op wise, we need to make sure to monitor their SATs. We're going to give them bronchodilators such as albuterol. We're going to give them mucolytic medications such as guaifenesin or even acetylcysteine. We are going to do what we call pulmonary hygiene, which is where they are going to do their incentive spirometer 10 times an hour. They are going to cough and deep breathe, and we are going to do chest physiotherapy hourly. That's chest physiotherapy. That's where you cup your hands and you pat on them pretty fast to help move any of the secretions. Because COPD is a chronic condition, we are only going to see them for a week at a time in the hospital, but then they're going to go on home and live the rest of their life at home without us sitting there holding our hands. So what does that mean? That means teaching is imperative because all of their life is being lived at home and they need to be as independent as possible. Or they might be in 24, long-term care, but oftentimes they're at home in the community. So good collaboration with a case manager or the social worker to organize and coordinate the delivery and management of O2 tanks, of nebulizers, of air compressors, oxygen compressors, home health care visits. Those home health care nurses are going to eval and assess their situations and do teaching. Just keep in mind this disease is lifelong. There's going to be tons of remissions, tons of exacerbations. There's going to be periods of depression and anxiety. and maybe even ineffective coping. So if we can coordinate with all of those different interdisciplinary professionals who can help make sure this patient manages their care very well at home. Okay, I'm going to make you recall some pharmacology information from last semester, as well as information that you learned from this semester from the asthma and COPD lecture combined. If you have not watched the asthma lecture yet, stop this video now and come back to it after listening to the asthma lecture. It is really important for students to have that necessary information prior to attempting this exercise. Otherwise, one might be a tad lost and disheartened. So, we are going to fast forward 15 years, and you've become very familiar now with Mrs. MacArthur because she ended up being diagnosed that one day that you were with her with stage 2 of COPD, and yes, she was experiencing a COPD exacerbation due to community-acquired pneumonia. She had an upper respiratory infection. Now, since then, she has progressed in her COPD and is now stage 4 or stage 5. And yeah, you were a great nurse. You gave her antibiotics, you gave her oxygen therapy, OT therapy, which is occupational therapy, about how to modify her lifestyle. And she did receive the flu and pneumonia vaccination, but time has gone by and now she's back again. And you need to give her 9 o'clock medications. I want you to pause this slide and tell me which meds you were planning on grabbing for her. 9 o'clock medications. Go. Did you select these? Good. The rule of thumb in most facilities is that meds are on time if they are given 1 hour before the scheduled time and 1 hour after the scheduled time. Great. Let's look at those 9 o'clock medications that I've bolded for you. 2 of these meds should not be given until we do further assessment of our patient's numbers. Specifically, we must check the blood pressure, the potassium level, and the drug level of 2 of these meds. Did you decide which ones require pre-assessment data? I wonder if you selected furosemide and theophylline. Now, I'm going to tell you that her blood pressure was 120/60. Her potassium is 4.1, and her theophylline level is 12. Right, 120/60, potassium 4.1, and theophylline level 12. Now, what do? Do you give the pills? 1 pill? Both of them? Well, her blood pressure is not hypotensive, so she can actually tolerate an expected dip in blood pressure with a diuretic. So give her the Lasix, the furosemide. Plus, her potassium level is only 4.1. Normals are 3.5 to 5, so she can actually tolerate a potential drop in potassium. The normal theophylline levels are 10 to 20, so she can actually be safely administered this medication. Good job. All right, so you gave her 9 o'clock medications, good, but let's look at this again. See all those highlighted drugs? One of these medications makes Mrs. MacArthur prone to thrush if she does not wash her mouth out. Which one of these 4 is it? Did you pick fluticasone and salmeterol, which is also known as Advair? Right, you did. Make sure she rinses and spits after every use, otherwise she will get thrush. Now, look at the highlighted ones. A precepting nursing student is helping you out and says they want to practice passing medications. Well, you tell the student, go get the meds, bring them back to me, and I'll double check it, and then we can go give it. So, this is what they bring you. As you were reviewing the student's medications prior to administration, you notice a problem with one of the meds that the student brought into the patient's room. Look very closely. Pause if you need to. Which medication did the student inappropriately grab and should go back into the medication dispenser machine? Once again, pause a few more times. Did you choose this one? Prednisone. Right. You send the student away with this tablet of prednisone, and then they come back with this. Is this correct? That's better. Always check your 5 rights of medication, the right person, time, route, dose, and in this case, the right drug. Prednisone tablet versus prednisone syrup. Last slide. It is just before lunch and you are prepping your 2 noon medications, which I have bolded for you. And as you look for her blood sugar in the electronic health record to know how much insulin you should be giving her, the tech tells you that Miss MacArthur refused his finger stick and that's why it's not there. And you ask, well, why did she refuse it? And the tech tells you, well, she says she's not that kind of diabetic. Well, now you have to go into the patient room. So you go into the patient room and Mrs. MacArthur insists that she has developed diabetes, yes, in the past few years, but isn't the kind of diabetic that has to take the blood sugar before meals and take insulin. So do you call the doctor and inform them of the mistake that insulin was inappropriately ordered? Do you respect her autonomy and even though the doctor ordered it, just mark the patient refused it? Or do you look at her med list to see if there are any other medications that can cause hyperglycemia? Did you figure out which answer? You are going to do the third option. You are going to look at her med list right there and see if any of these medications can cause hyperglycemia. Now, I just made it easier on you because the guilty culprit that causes hyperglycemia is right in there, and that's why we have to treat our patient with insulin. Did you pick the right medication? Prednisone. That's right. Prednisone causes hyperglycemia, and that's why we have to give patients insulin sometimes if they are diabetics and receiving steroids. And that is it, students. You have reached the end of the COPD lecture. I hope you enjoyed it, and if you have any questions, just let me know.